Okay, so welcome everybody. It's quite a massive turnout tonight, so I really appreciate that on a dark Tuesday evening. So today I'm going to talk about stroke. So I'm Joe Wood. I'm a fifth year student doctor at the University of Liverpool. I've sat my finals, and so hopefully I'll be able to give you a few tips and tricks about what to do about stroke. I'd just like to preface this by repeating the fact that this is based on UK guidelines, and everything is best to the best of my knowledge, but of course there may be some inaccuracies. So always follow your national and local guidelines and work within your competencies. Okay, so what will I be covering today? So the definition of stroke and TIA and how these two differ. The symptoms of stroke, how to identify it, what investigations to do initially, how do we manage stroke in the short term and long term, what are the complications of stroke. So start off with the definition of stroke. So it is an acute neurological deficit lasting more than 24 hours, and it's caused by cerebrovascular etiology. So stroke is divided up into two main categories, which is ischemic, which is where there is a blockage in a blood vessel, or hemorrhagic, caused by a bleed. So the majority of them are ischemic. 87% of cases are ischemic stroke, and 3% are subarachnoid hemorrhages. So how does this differ from a TIA? So a TIA is, again, a neurological deficit, but the symptoms of it resolve completely within 24 hours. And an important point to make about TIAs is it cannot be explained by hypoglycemia, which can mimic TIAs. So it's important to do a BM on patients to make sure it's not hypoglycemia. So if you're from the UK, you might be familiar with the picture on the right. This is a public guidance initiative called FAST. So face, arms, speech, time. And it's a really effective way of getting the general public to understand the signs of stroke, because time is of the essence. So other symptoms of stroke, apart from what's on the right, is loss of balance, vertigo, dizziness, coordination problems, visual disturbances, numbness, weakness in the face, arms or legs, particularly on one side. Dysphagia, which basically means difficulty swallowing, a headache, such as in subarachnoid hemorrhages, you can have a really severe headache, and loss of consciousness. So those are some of the key signs of symptoms of stroke. So what are the risk factors? So with a lot of things which are like cerebrovascular, age, a history of TIA or stroke is really important. Any family history of young strokes in the family, hypertension, smoking, these all increase your cardiovascular risk anyway. Diabetes, AF, which can be a cause of ischemic stroke, any cardiac comorbidities, and if stenosis of the carotid arteries. So it's good to bear this all in mind if you're ever going to go and see a patient who you think might be having stroke. Think about what you're going to ask in the history to ascertain these points. So I just want to make a small point about something called the penumbra. So this is an area of salvageable brain tissue. So when you have an ischemic stroke, you have something called the ischemic core. Now, this is the area of brain which is directly affected by the loss of blood supply. However, surrounding this, you have something called the penumbra, which is salvageable, as I said. So if you start treatment early enough, promptly, you can reverse this before it becomes ischemic. And the old adage, time is brain, is very true in this sense, because after 4.5 hours, the penumbra is not usually salvageable. So it's important to act as fast as possible. Okay, so I thought I'd start off by going through a case. So you're in the A&E department, and a 77-year-old male comes in, and he's got weakness on his left arm and slowing of his speech. He has a past medical history of hypertension and type 2 diabetes. Medication includes amlodipine for his hypertension, and he takes metformin and sitagliptin for his type 2 diabetes. He admits being a smoker with a 50-pack year history. So if anybody would like to just say in the chat, that's initially what we've got. What else do you think we should be asking? Any suggestions in the chat?
So someone has said family history, time of onset, when did the symptoms start? Yeah,
all really important points. So basically, you're right, we need to know more about this presenting complaint, don't we? So here's a little bit more information. So he was sitting down watching television at the time. His partner noticed slowing of speech. He dropped his cup of tea and couldn't move either his arm or leg. He started to panic then, and his heart started going fast. But no visual disturbance, no headache, no sensory problems, no vertigo, no nausea, vomiting, loss of consciousness, or chest pain. So we know a little bit more about what happened. So now we've got initial history of the patient. What's important to do next? Anybody got any ideas?
Someone said CT head. Another person said blood glucose.
Yeah,
AB, and then someone's just mentioned ABCD.
Yeah, so you're all correct. These are things that would happen next, but initially we want to assess the patient. It's an emergency setting, so an A2E assessment is absolutely appropriate in this case. So in emergency settings, it's always important to remember A2E because it makes sure that you're systematic and you don't miss anything important. So if you're not familiar with this, it just stands for airway, breathing, circulation, disability, and exposure. So I'll go through what we assess in each point. So in this patient, we assess the airway. It's patent, no stridor, snoring, anything like that. He's able to speak in full sentences, but it's a bit slurred. Breathing. So he's got a bit of a high rest rate there, but he's saturating fine on room air. No other respiratory problems on auscultation or anything like that. So we can move on to C. Blood pressure is 160/87, heart rate of 95, heart sounds normal, capillary refill is normal, and he's well perfused. So next, disability. So we want to do a GCS assessment on him. And a BM was taken, it was 8.5, which is a little bit on the high side. So maybe his diabetes isn't controlled that well. And his temperature is normal. So finally, exposure. So if possible, expose the patient, see if there's any rashes or anything like that, because things like meningitis can present with a rash, and you don't want to miss it and think it's a subarachnoid hemorrhage or another type of stroke. So if you can, expose the patient and check. So a side note, I thought I'd just go through the Glasgow Coma score. So this is something that we use in the UK, and it's a way of measuring level of consciousness and if somebody's had a brain injury, how severe that is. So it's split up into 3 parts: eye, verbal, and motor response. So if a patient can spontaneously open their eyes, they get 4. If no response, they get 1. Again, verbal speech, so starting off with orientated normal speech, becoming more confused to only sounds and then no response. And then motor response, again, 6 is the best, 1 is the worst. So the minimum score you can get on a Glasgow Coma score is 3 for absolutely no response, and the highest is 15. Anybody with a Glasgow Coma score of 8 or less, you'd be concerned about the patient maintaining their own airway, and you'd be thinking about calling in an anaesthetist to help with intubation. So the Glasgow Coma score is useful in head injuries, like I've got in this slide, but also for assessing the effects of a stroke. So it's a good idea and a good habit to get into to start remembering what these scores are, so you can do it quickly. Okay, so I've got a question now. So I'm going to give you a patient and I'd like you to work out what you think the Glasgow Coma score is for them. So you're called to assess a GCS. So this is a description of the patient. They're able to open their eyes spontaneously, but they can only make groaning noises. When you apply painful stimulus, they localize to pain. If we could put up the poll for the first question, let's see what some of the results are.
Whilst people are answering that, Joe, I've had a private question asking, do you need to know GCS for finals?
That's a bit of a hard question. It depends where you go. I mean, it's a really important skill to know, not just for finals, but when you're working as a doctor. So I learned it, and I suggest that you do too. It is useful to just get your head around it. It's one of those scores that in the moment you need to know it.
Thank you.
I'd learn it. So it looks like the majority of people are saying 11, and that's the correct answer. So I'm sorry I didn't put up the tables up on the screen, but yeah, 11's the correct answer. So question 2, here's another one just quickly. So they don't open their eyes at all, they don't make any sounds. When you apply painful stimulus, there is abnormal flexion. So what do you think this is? Okay, so yeah, the majority seem to be getting it. So yeah, the answer is 5. So yeah, just get into the habit of just learning the tables and what scores what, because especially the motor response can be confusing to remember because they all sound similar. But yeah, well done. Okay, so back to the case. So we've got some observations now, like when we went through the A to E. So neurological examination. So yep, facial drooping was noticed on the left side of face with a bit of slowing of the speech. So his right lower limb, 5 out of 5 for power. Lower limb left, 2 out of 5. So just to mention, this is the Oxford scale for muscle power. Another scale which is useful to remember. So starting off with normal power, and against some resistance, against gravity only and no resistance. Without gravity, visible contractions, but no movement of the arm, and then nothing. So this patient in their left lower limb has movement without gravity. So they're able to move their leg when gravity is eliminated. So there's a distinct difference between the two sides. So a really useful scale to use is the Rosia stroke scale. So this basically is a way of telling whether the symptoms you're presenting with, is it acute stroke and is it likely? Because there are a lot of other things that can mimic stroke, such as like hypoglycemia that I've said before, seizures, syncope, things like that. So the scale, I'll go into it on the next slide, but it asks about weakness, speech problems, disturbances, and any score of 1 or more means that an acute stroke is likely. So this is the Rosia score. As you can see here, it says GCS, BP, BM. You score minus points if you've got anything that suggests it's not a stroke, and then positive 1 point for each of the signs which suggest you might have a stroke. So stroke mimics, so there was a bit of research done into this. So this article from 2006, seizures make up quite a large proportion of stroke mimics, sepsis, toxic and metabolic problems, other things, delirium, dementia, and migraine with aura, things like that. So there's a lot of things which can present like stroke, but aren't actually stroke. So it's important to get a good history. When did it start? Onset, character. Have you had anything like it before? Family history, as somebody mentioned. So yeah, all really important things to get from the history. So important bloods on a patient like this. Now we're going to start to investigate them. FBC, UNE. A serum glucose is also useful. You can consider doing a troponin because MIs can present alongside stroke, and then a clotting screen. Imaging, so you'd want to do a chest X-ray, and a non-contrast CT head is the main investigation, as somebody said in the chat before. And you'd also want to do an ECG. Okay, so non-contrast CT head. If you have any of these points, the BMJ best practice suggests that you should really be getting your CT head within 1 hour. So indications for thrombolysis or thrombectomy. So treatment of the stroke can happen. You'll want to get your scanning early. Anticoagulation, if they're a known bleeder, reduced consciousness or fluctuating or progressive symptoms. Any signs of raised intracranial pressure like papilledema, whether they've got neck stiffness, fever, or whether they've got a severe headache at onset, which might suggest a subarachnoid hemorrhage. So these are indications for getting a CT head pretty early on. So in this patient, the bloods were unremarkable, apart from a high glucose and a bit of tachycardia. I mean, this might be down to pain or nervousness, but yeah, the rest of the bloods were normal. Yeah, so we'll look at the CT head now. So this is the CT head of this patient. So very handily circled on the slide here, the CT head. So you're looking at the left side, left hemisphere, and that is an ischemic stroke he's had, a lacuna stroke. So to make things more complicated, unfortunately, there's different types of stroke you can have depending on what vessel is blocked. So this is for ischemic strokes. So you can have a total anterior circulation stroke, a partial anterior circulation stroke, lacuna, or a posterior circulation stroke. So this is the TACS criteria. To get a total anterior circulation stroke, you need to have all three components of this criteria. So you need to have unilateral weakness with or without sensory problems in the face, arm, or leg. Homonymous hemianopia, which I'll go on to discuss in a minute, and higher cerebral dysfunction. For partial anterior circulation strokes, you only need 2 of these 3 criteria. And lacuna and posterior circulation stroke have their own criteria as well. So as I said, total and partial refer to this criteria: unilateral weakness, visual disturbance, and higher cerebral dysfunction. And lacuna stroke presents with other symptoms such as pure motor hemiparesis, so lack of motor movement on one side. It can be pure sensory as well. Ataxic hemiparesis, dysarthria, or it can be a mixture of sensory and motor disturbance. And a posterior circulation stroke tends to have brainstem or cerebellar syndrome signs, including loss of consciousness, and can just have isolated visual disturbance as well. So there's quite a wide range of different strokes and different symptoms for each. So got some more questions here. So these are some visual field defects. The area in blue signifies the area of vision that is lost. I'd like you to have a look at the number 1 and tell me of those 4 which you think it is. Very encouraging, everybody's got it right so far, excellent. Bi-Temporal Hemianopia, that's correct. So this means loss of vision bilaterally on the outside bit of the vision. And this can be caused by a lesion in the optic chiasm area, such as a pituitary adenoma, something like that. Brilliant. Okay, we'll move on to number 2. Oh, don't look at that. That was the answers. Okay. Then we have number 2. Yep, brilliant. Right, homonymous hemianopia. Sorry, I struggle to say these, but yep, you're right. That's correct. So we'll move on to number 3. Excellent. Yep, left nasal hemianopia. For those that are not familiar with these, if the vision is lost on the nasal side, it's nasal. If it's the outer edges of your vision, it's temporal. Yeah, brilliant. Okay, and number 4. Brilliant. Right, homonymous hemianopia with macular sparing. That's right. So the difference between 2 and 4 is macular sparing is seen when one hemisphere of the visual cortex is affected. So that's where you get macular sparing. So if you have a stroke in just one side of the visual cortex. Brilliant. So those are the answers. So here's a little diagram just to explain it in more detail. So the way it works is your right field of vision bounces off the opposite side of your opposite side of your eye, crosses over an optic chiasm, and then your field of vision, so the left from both sides of your eye will go to one side, and the right side of your vision from both eyes will go to the other. So homonymous hemianopia, which you can see in stroke, occurs because the right side of the brain has visual pathways from the left side of the vision of both eyes, and vice versa. So you cannot see anything on the right-hand side of your vision of both eyes. And this is highlighted on this diagram by where the stroke will be happening in this patient to produce this visual field defect. Okay, so back to the patient. So we've ruled out this hemorrhagic stroke. This is an ischemic stroke in this patient, so we can start initial treatment. Does anybody know roughly how we'd initially treat this patient? Just put it in the chat.
I'm just waiting on answers now. Okay, so someone has said thrombolysis, alteplase, supportive, stop anticoagulants, alteplase. Yeah.
So yeah, you're right. Alteplase that's true. It depends on the time at which since symptom onset, but that's definitely part of it. You'd also want to start aspirin. So if they're able to swallow, which you might not be able to in a stroke patient, you want to give 300 milligrams orally. And if they can't, I think you can give it rectally as well. So you can give that. But like somebody mentioned, alteplase is an option. So that depends on when they present. So if it's before 4.5 hours, thrombolysis can be considered. Other things that you can do, supportive care, just like somebody mentioned, if they're on antiplatelets, yeah, so VT prophylaxis, starting a statin after 2 days as well. And you can consider mechanical thrombectomy as well. But before 4.5 hours, you can do this as well as start thrombolysis. It's important, sorry, I'll come on to contraindications in a minute. Just a little side note about how it actually works rather than just tell you what it is. I thought it'd be useful to just explain it quickly. So this might be useful for the younger years in the audience. So plasminogen is converted to plasmin in the body, and plasmin causes the degradation of fibrin. So tissue plasminogen activators such as alteplase cause the transition from plasminogen to plasmin. So you get this fibrin breakdown, which helps in ischemic stroke to break down the products of the fibrin. So that's why we use it. However, there are contraindications to this. So this will usually be assessed by a stroke physician with a lot of experience, but it's important to pick up on the history. So if they have an intracranial hemorrhage on the CT, it's an absolute contraindication. If they had neurosurgery or head trauma in the past 3 months, if they've got wildly uncontrolled hypertension, that's going to be a risk if they had thrombolysis, so that's not an option. History of intracranial hemorrhage. If they're actively bleeding, it would just make that worse. So any bleeding anywhere in the body, intracranial AVMs, neoplasm, known aneurysms, suspected or confirmed endocarditis. So those are some of the absolute contraindications. However, there are some which are relative, which on a case-by-case basis, they have to be considered. So if a patient's improving, then maybe thrombolysis might not be needed. If they've had major surgery or serious non-head trauma in the past 2 weeks, maybe not. History of hemorrhage from the GI or urinary tract, seizure at the stroke onset, arterial puncture, recent LP, post-MI pericarditis, or whether they're pregnant. So things have to be weighed up before going ahead with thrombolysis. It's not for everybody, is the message I'm trying to make, really. So the other type of treatment I mentioned was the mechanical thrombectomy. So this is another treatment which has to be assessed by stroke consultants. So if it's a proximal anterior circulation stroke, PACS, confirmed on the scan, you can offer thrombectomy within 6 hours of onset, together with the thrombolysis. So considering thrombectomy as soon as possible in patients between 6 hours and a day, there is a potential to salvage the brain tissue. So that's proximal. So yeah, considering thrombectomy together with IV thrombolysis as soon as possible, up to 24 hours, as shown on perfusion imaging. This includes people who wake up with strokes where we don't know when exactly the stroke happened. It could have happened during sleep, but you don't know exactly when it happened. That's what wake-up strokes mean. So mechanical thrombectomy is another treatment option. So longer term, after initially you stabilise the patient and they've been assessed, VT prophylaxis, early mobilisation. The stroke MDT is really important to get the patient best support, nutritionists, physiotherapists, OTs, consultants, and many more. It's a real team effort, and recovery can be slow, so it's important to get as much support as possible. Statin therapy can be started in stroke patients after 2 days. So just go on to a second, this shorter case now. So 34-year-old female patient presented to A&E with a sudden onset global headache. She describes this as the worst headache of her life, and she vomited at the time. She has a known past medical history of polycystic kidney disease. Okay, so hopefully at this point you're thinking maybe this might be subarachnoid hemorrhage. So in hemorrhagic stroke, the management's a bit different. So again, as usual, aim to stabilise the patient. So we do a full A2E assessment, as I went through before. If their Gcs is 8 or below, we consider intubating because they might not be able to maintain their airway. Are they hypoxic? If so, oxygen. So if the hemorrhagic stroke is confirmed, immediately we need to speak to neurosurgery to get their opinion and see if the patient can have operation. It's important, if they are on warfarin or any other anticoagulation, to reverse this, because this may be very well the cause of the stroke. So vitamin K is the antidote for warfarin, and the monoclonal antibody idarucizumab is the one for dabigatran. So yeah, reversing anticoagulation if possible. So yeah, standard things for monitoring: GCS assessment, blood glucose, blood pressure, SATs, temperature, hydration, also intracranial pressure sometimes, and also if they're having seizures, is important to monitor. So management of hemorrhagic stroke is different to ischemic stroke. So you can give nimodipine, which is a medication, which I'll talk about later. Aneurysmal subarachnoid hemorrhage, which this patient has got, can be treated coiling or clipping. The majority in the UK are coiled. So that's the surgical treatment for it. Initial CT, if there's no hemorrhagic stroke that you can see, but you suspect there might be, lumbar puncture should be done 12 hours following this to look for something called xanthochromia, which basically means blood in the CSF, which is a sign of subarachnoid hemorrhage. Okay, so nimodipine. We'll have the next poll up, please. So what do you think nimodipine is? What class is it? And what is the mechanism of action? Yeah. Okay, the majority have got it right. So yeah, you're correct. The brilliant. So nimodipine, when you have a stroke that is a hemorrhage, you can get something called vasospasm, and nimodipine as a calcium channel blocker prevents this from doesn't prevent it from happening, but makes it better, reduces it. So that's why it's given in addition to any surgical intervention, because it helps reduce the bleeding. Not all patients are, just like with ischemic stroke, not all patients are eligible for more intense intervention, and this is assessed by the specialist and seniors, whether it's worth giving it a go. And if they're not for surgical intervention, it's about supportive care and monitoring of the points that I mentioned before. So I wanted to mention another scoring system. Sorry to bombard you with them, but this is another important one. So TIAs can be a warning sign of a larger stroke that's coming down the line, maybe in a week or 2 weeks' time. And the ABCD2 tool allows you to assess the likelihood of this happening. So A for age, B for blood pressure, C for clinical features, D for duration of the symptoms, and diabetes status. And you basically just go through the patient's history, add them up, and see what their risk is of having a stroke after a TIA. And some of the figures are quite staggering. So the difference between a score of 3 and a score of over 5. So you can see a 7-day risk is 1.2%. So, you know, about 1 in 100 roughly. And then over 5, it's just over about 1 in 10 or worse than that. So it's a useful tool for assessing patients who've had a TIA. So further management of stroke. So first line for ischemic stroke is clopidogrel. If they can't have clopidogrel, aspirin, and I can't pronounce it, dipyridamole is the alternative to clopidogrel. Patients can be considered for carotid artery endarterectomy. However, this is really dependent on the level of stenosis. And as you can see here, some of the criteria, you need to have over 70% stenosis, and in some cases symptomatic to be eligible for treatment. Standard things, lifestyle changes, better blood pressure management, blood glucose, getting control of diabetes is all really important. Patients who've had a stroke should not drive for a month after their stroke, and also have statin therapy if they have not already started it. So a little bit about stroke recovery. So the 3 domains that the NHS defines stroke recovery by is movement problems, cognition problems, and psychological. So movement, we all know what that means. Can't move one side of the body, or weak, not able to walk properly, complete activities of daily living, problems with balance. Cognition, sometimes we forget about this, but they might have problems with their communication skills. They might not be able to speak like they usually did. Their memory might be affected by it depending on where in the brain. And the culmination of all this is the psychological impact, which a lot of people forget. Not being able to do what you used to do can be really depressing, can give patients anxiety. So like a psychological input is also useful in stroke recovery. So when patients are recovering, this is the modified ranking scale. It's quite a commonly used scale, and it's for assessing the level of disability following a stroke. So assigning a patient a number on this scale allows healthcare professionals to standardize activities of daily living. So we know the level of disability. So 6 is dead, and 0 is they've got no symptoms of their stroke. And the majority of stroke patients fall somewhere within this. So up the top end, 5, a patient might require constant nursing care, not able to look after their own bodily needs. 3 can walk alone, which is a big benefit to people post-stroke, to have that independence. 2, unable to carry out all of the activities, but can do a lot for themselves. And 1, just some symptoms. So there's a huge spectrum, and it really depends on how big the stroke was at the time and how quickly it was treated. But patients can take months, maybe years, to improve their disabilities, and some might never fully recover. So it's another useful scale to just have in the back of your mind, or know of. So that's everything that I wanted to talk about. The main take-home messages are ischemic stroke and hemorrhagic stroke are different. I think it's important for you to go away and revise the management yourself, because it's quite complicated. I've tried to summarize it as best as I can, but I'd advise you go and look at it yourself. Get used to having a look at CT scans as well. There's been a lot of scoring systems that I've mentioned, but they are useful and they are important. GCS is a general neurology type scoring system, which is used in a vast array of different neurological problems. So that's really a good one to learn. Rosia and ABCD2 are important as well. So go away and have a look at them yourself. Yeah, so that's all I wanted to say. So thank you very much for attending this teaching tonight. Okay.